Management of acute type B aortic dissection. Complications in acute type B aortic dissection. No uniform criteria to define complicated. 15 to 20% of cases. Impending rupture. Malperfusion syndrome, 10%. Hemodynamic instability, 15%. Refractory hypertension. Refractory hypertension. Hypertension persisting despite 3 different classes of antihypertensive therapy at maximal recommended or maximal tolerated doses. Malperfusion syndromes. About 10% of patients with type B aortic dissection. Dynamic malperfusion caused by branch vessel occlusion of the true lumen by the pressurized false lumens. Static malperfusion caused by propagation of the dissection into branch vessel ostia with distal vessel occlusion. Malperfusion syndromes. Mesenteric ischemia. Abdominal pain, nausea, and diarrhea. Associated with an increase in laboratory markers, bilirubin, amylases, hepatic, and intestinal enzymes. Highly devastating and has a major impact on early mortality. Lower limb ischemia. Relatively benign and surgical intervention should be performed in symptomatic patient. Spinal cord ischemia. Paraparesis or paraplegia. Strategy central aortic repair, peripheral repair, aortic replacement. Fenestration. Endograft. Re-entry fenestration. Peripheral repair. Graft bypass. Stenting. Therapeutic aim. To restore the perfusion of the organs. To stop/limit the dissecting process to protect the organs. A 59-year-old male with history of hypertension and COPD presented with abdominal pain, painful, pulseless right lower extremity. Celiac A. Right CIA. FL. Lieutenant RA. Right RA. Stent graft placement. IVUS/T superior to angiography for identifying primary and distal re-entry tears. Documenting guide wire position in the true lumen. Assessing seal zones. Detecting endoleaks. Assessment of the ascending aorta to be mandatory at the conclusion of each TEVA case to assess for retrograde ascending aortic dissection. Circulation. 2005:112:I264. Stent placement. Uncovered stents improve flow. Inadequate relief of dynamic obstruction after surgery. Static obstruction of abdominal aortic branch vessels, which is typically unaffected by proximal aortic stent graft treatment and fenestration. The use of uncovered stents in the aorta and side branches may improve flow in aortic dissection, Figure 4. The most common indications include 1. Inadequate relief of dynamic obstruction after surgery, stent graft treatment, or fenestration, and 2. Static obstruction of abdominal aortic branch vessels, which is typically unaffected by proximal aortic stent graft treatment and fenestration. In most cases of symptomatic static branch vessel compromise, attempts are made to restore more normal flow dynamics by placing an uncovered stent via the aortic true lumen into the true lumen of the involved branch. Impending rupture/rupture. Persistent pain despite good blood pressure control. Aortic dissection with persistent uncontrolled hypertension. Evidence of dissection progression despite optimal medical management. An increase in periaortic hematoma and hemorrhagic pleural effusion in 2 subsequent CT examinations. Requires sealing off the primary tear as well as the site of the leak. Frequently necessitates paving the entire thoracic aorta when the site of the leak is unclear. J.M. Cole Cardiolin 2008 1 to 395 402. Circulation 2010 122 to 1283 to 9. Refractory hypertension. International Registry of Acute Aortic Dissection, IRAD. Trial data showed that in-hospital mortality after medical management was significantly increased in average-risk patients with type B aortic dissection under medical therapy with refractory hypertension/pain compared with those without these features. 35.6% versus 1.5%, p 0.0003. Circulation 2010 122 to 1283 to 9. Open surgery. Uncomplicated acute type B aortic dissection. Medical management. Anti-impulse therapy. Uncomplicated dissection. Lack of appropriate facilities. Presence of comorbidities or morphology that made open surgery or ever not feasible. IRAD, 3-year survival equals 78%. Late aortic-related complications equals 25 to 50%. Prophylactic TEVA. Thrombosed false lumen predicts lower event rates after type B dissection. Randomized comparison of strategies for type B aortic dissection, the investigation of SD and grafts in aortic dissection, instead, trial. Found no difference in the primary endpoint of all-cause mortality at 2 years. Thoracic false lumen thrombosis, TEVA Medical MX, 91.3% versus 19.4%, p less than 0.001. High rate of aorta-related deaths in the TEVA group resulting from periprocedural technical complications. Circulation. 1993 87 to 1604 15. Circulation. 2009 120 to 2519 to 28. High-risk features of uncomplicated type B dissection. Initial aortic diameter greater than or equal to 4.0 cm with patent false lumen, Euro. Initial false lumen diameter greater than or equal to 22 mm in proximal DTA. IMH with poor in proximal DTA. Euro J Vascendovasc Surge. 2006 32 to 349 to 55. Euro J Thorac Cardiovasc Surge. 2007 134 to 1163 to 70. Circulation. 2010 122, S7480. JM Col Cardiol. 2007 50 to 799 to 804. Long-term management. Specific predictors of follow-up mortality include female gender, prior aortic aneurysm, atherosclerosis, pleural effusion, in-hospital acute renal failure, hypotension or shock, beta blockade and blood pressure control. IRAD, calcium channel blockers at discharge was associated with improved long-term survival selectively in medically treated type B dissection patients. Greater than 1/3 of patients will require surgery for aortic-related complications within 5 years of the initial dissection. Serial imaging at 1, 3, 6, and 12 months after discharge, and annually. Outcome data from medical therapy. Early mortality rate equals 6.4%, 95% C, 5.1% to 7.9%. Stroke equals 4.2%, 95% C, 2.3% to 7.4%. Spinal cord ischemia equals 5.3%, 95% C, 3.4% to 8.4%. 5-year survival rates ranged from 70.2% to 89%. Aortic adverse event freedom, including aortic death, rupture, new dissection, enlargement, re-intervention, ranged from 75% to 88.5% at 5 years, but there were variable event definitions among studies. Combine early neurological complication event rate of 10.1%, 95% C, 7.5% to 13.5%. Outcome data from TEVA. In most of the papers, indication for TEVA was complicated acute type B dissection. Criteria for defining complicated were variable. Early mortality rate equals 10.2%, 95% C, 9.0% to 11.6%. Stroke equals 4.9%, 95% C, 4.0% to 6.0%. Spinal cord ischemia equals 4.2%, 95% C, 3.3% to 5.2%. 5-year survival rates ranged from 56.3% to 87%. Freedom from aortic events ranged from 45% to 77% at 5 years. Outcome data from open surgery. Early mortality rate equals 17.5%, 95% C, 15.6% to 19.6%. Stroke equals 5.9%, 95% C, 4.8% to 7.3%. Spinal cord ischemia equals 3.3%, 95% C, 2.4% to 4.5%. 5-year survival rates ranged from 44% to 64.8%. Freedom from aortic events ranged from 58.7% to 68% at 5 years. Medical therapy versus TEVA and open surgery versus TEVA. Invalidated by unbalanced populations, unmatched illness conditions and rates of complicated versus uncomplicated cases of patients assigned to each treatment. Complicated cases open SX, TEVA. Uncomplicated cases medical treatment. Comparison of early, 30 days/in hospital, outcomes with medical therapy and TEVA in acute type B aortic dissections. Subacute type B aortic dissection. Very limited outcome data. Instead, investigation of stent grafts in aortic dissection, trial. Primary success rate equals 95.7%. Early mortality equals 2.8%. Stroke rate equals 1.4%. Spinal ischemia equals 2.9%. Required secondary procedures equals 18%. Virtue, Valiant thoracic stent graft evaluation for the treatment of descending thoracic aortic dissections post-marketing surveillance registry, 24 patients with complicated subacute type B aortic dissections treated with TEVA. Primary procedural success rate equals 100%. Early mortality rate equals 1.8%. Late deaths equals 0%. Strokes or cases of spinal cord ischemia equals 0%. Negative prognosis in the subacute phase. Change in aortic morphology, expanding diameter 4 mm, new onset of periaortic hematoma, and/or pleural hemorrhagic effusion. Refractory hypertension. Recurrent thoracic pain. Malperfusion. Subacute type B aortic dissection.